All right, let's dive right into this continuous high-yield explainer. We're going to use a warm, immersive visual theme to really master these cardiovascular clinical scenarios. Let's get started. Section 1. Surgical Cardiac Arrest Protocols.
Moving straight to the operating room with question 12. What is the principal pharmacological component of cardioplegia solutions used to arrest the heart during open heart surgery? And how does it achieve rapid diastolic cardiac arrest? Are we looking at A, a high concentration of sodium, B, a high concentration of potassium, C, a pure calcium infusion, or D, high-dose epinephrine? Read through the scenario and options and just take a beat to let it sink in.
And the answer is B, a high concentration of potassium. Now, what's really interesting here is how that high potassium instantly forces the heart into an energy-conserving diastolic arrest. By infusing cold potassium right into the coronary arteries, usually around 15 to 30 milliequivalents per liter, you literally shift the equilibrium potential of the myocardial cell membrane from negative 85 millivolts up to roughly negative 50 millivolts. This massive depolarization completely inactivates the voltage-gated sodium channels, so there's absolutely no way to generate an action potential. It instantly arrests the heart in a totally relaxed state, giving the surgeon a perfectly still field to work on. Section 2. Acute infarction and intracardiac masses. Leaving the OR, let's transition to the ICU for question 13. We have a 68-year-old male who develops a massive transmural anterior myocardial infarction. 3 days later, bam, he experiences sudden, severe dyspnea, hypotension, and a brand new, harsh, holosystolic murmur at the left lower sternal border with a palpable thrill. Now, monitoring reveals a significant step up in oxygen saturation between the right atrium and the right ventricle. So, what mechanical complication happened here? Is it A, acute mitral valve chordal rupture, B, left ventricular free wall rupture with tamponade, C, post-infarction ventricular septal rupture, or D, pseudoaneurysm formation? Pay close attention to that oxygen step up in the right ventricle, guys. It is the absolute key to nailing this diagnosis. The correct choice is C, post-infarction ventricular septal rupture. This brilliantly illustrates how coagulative necrosis and macrophage debridement actually physically weaken the septum right after a transmural MI. It leads to this lethal mechanical shunt. You can confirm this specific diagnosis by finding an oxygen step-up of 5 to 10% or even greater in the right ventricle compared to the right atrium. That basically proves highly oxygenated blood from the left ventricle is crossing over through a brand new septal defect. Think about it. If this were just mitral regurgitation, you'd see that oxygen step up in the left atrium, not the right ventricle. Okay, question 14. A 58-year-old female presents with progressive fatigue, weight loss, low-grade fevers, and a really specific positional dyspnea. It actually worsens when she sits upright. An echo reveals a large, mobile, pedunculated mass right inside the left atrium that prolapses through the mitral valve orifice during diastole, creating this classic tumor plop sound. So what's the most likely diagnosis? A, rhabdomyosarcoma, B, cardiac myxoma, C, lipoma, or D, metastatic renal cell carcinoma? Listen closely for that tumor plop and those positional symptoms. They give the whole thing away. And the answer is B, cardiac myxoma. So the crucial takeaway here is that myxomas don't just mechanically obstruct the mitral valve via gravity, which by the way perfectly mimics mitral stenosis when the patient sits upright, but they also cause systemic symptoms through the release of interleukin-6. That totally explains her fever and the weight loss. Now, myxomas are the most common primary adult heart tumors. About 75% of them arise right in the left atrium, usually anchored to the borders of the fossa ovalis. Oh, and you've got to remember, bits of them can easily break off and cause severe systemic embolic strokes. It's a really high-risk situation. Section 3. Mechanical circulatory support. Let's look at question 15. When the heart fails mechanically, we rely on advanced devices. So, which mechanical circulatory support device is designed to be placed percutaneously via the femoral artery, across the aortic valve, and into the left ventricle, utilizing an axial flow Archimedes screw pump mechanism to actively pull blood out of the LV and vent it into the ascending aorta? Is it A, the intra-aortic balloon pump, B, the Impella ventricular support catheter, C, veno-arterial ECMO, or D, the tandem heart? Try to visualize that exact mechanism, an active screw pulling blood right out of a failing ventricle. You guessed it, the correct answer is B, the Impella ventricular support catheter. The Impella is basically a percutaneous microaxial continuous flow pump. It actively aspirates blood directly from the left ventricle cavity and just expels it right into the ascending aorta. By doing this, it drastically lowers myocardial oxygen demand because it's physically unloading the ventricle. At the same time, it's simultaneously increasing systemic forward cardiac output during high-risk interventions or when a patient is in profound cardiogenic shock. Question 16. Let's test your knowledge on the precise timing required for balloon counterpulsation. When an intra-aortic balloon pump is positioned within the descending thoracic aorta, what are its two primary physiological benefits, and how exactly are they mechanically timed with the cardiac cycle? Does it A, inflate during systole and deflate during diastole? B, inflate during early diastole and deflate immediately prior to systole? C, deflate during diastole and inflate during systole? Or D, does it remain continuously inflated? The answer is B. This two-step mechanical rhythm is ingenious. It acts like a giant vacuum, significantly reducing the workload the failing heart has to overcome. It's all based on the principle of counterpulsation. Step 1 happens when the balloon inflates in early diastole. This displaces aortic blood backward to really augment coronary perfusion pressure. Then, step 2 occurs when it deflates right before systole. That sudden deflation creates a central aortic vacuum that actively lowers the afterload. It literally sucks the blood forward, making it dramatically easier for that failing left ventricle to eject.
On to question 17. A patient develops severe biventricular cardiogenic shock and acute respiratory failure following a massive structural cardiac event. The medical team decides to initiate extracorporeal membrane oxygenation, or ECMO. Now, think carefully here. Which modality must be chosen to provide full mechanical circulatory support for the systemic organs? A, veno-venous ECMO, B, veno-arterial ECMO, C, portal mesenteric ECMO, or D, isolated pulmonary artery venting? Does this patient just need oxygenation or full hemodynamic pumping power?
The correct choice is B, veno-arterial ECMO. This perfectly highlights the functional difference between these two main modalities. See, VV ECMO extracts venous blood and returns it right back to the venous system. It literally only handles pulmonary gas exchange. Because VV ECMO completely relies on the patient's own failing heart to pump that newly oxygenated blood forward, it's pretty much useless in circulatory failure. VA ECMO, on the other hand, extracts venous blood and returns it under pressure straight into the systemic arterial tree. It bypasses both the failing heart and the lungs to provide total hemodynamic support. So, for full circulatory collapse, VA ECMO is absolutely the mandatory choice. Section 4, Pericardial, Aortic, and Valve Disease. For our final round, question 18, we're evaluating chronic, calcific, and restrictive structural diseases now. Constrictive pericarditis is a chronic condition that mechanically restricts the diastolic filling of the heart. Consider how you'd mechanically fix a heart trapped inside a rigid shell. What is the definitive surgical treatment for symptomatic advanced constrictive pericarditis? A, daily needle pericardiocentesis. B, total surgical radical pericardiectomy. C, insertion of a permanent pericardial peritoneal shunt catheter. Or D, lifelong systemic anticoagulation with warfarin. The correct answer is B, total surgical radical pericardiectomy. Constrictive pericarditis essentially means there's a non-compliant calcified pericardial sac that severely restricts normal diastolic expansion. And because this restriction is 100% mechanical, medications are completely useless here. The surgeon actually has to physically strip away that dense epicardial shell. They perform what's called a phrenic-to-phrenic resection of the fibrotic pericardium to completely free up both ventricles and finally restore normal filling dynamics. Moving to question 19. A 7-year-old male with a history of severe multivessel coronary artery disease has clear indications for a CABG operation. Now, which of the following coexisting parameters represents a relative contraindication to performing a CABG on cardiopulmonary bypass, steering the surgeon toward alternative off-pump techniques? A, a history of an uncomplicated laparoscopic cholecystectomy 5 years ago. B, an active, severe diffuse porcelain aorta. C, a mild left-sided inguinal hernia. Or D, essential hypertension managed with a single oral agent. Try to identify the high-risk vascular finding that would force a surgeon to abandon traditional clamping altogether. The answer is B, porcelain aorta. A porcelain aorta is characterized by heavy, brittle, circumferential calcification of the ascending aorta. Clamping a porcelain aorta can literally fracture the brittle vessel wall. That leads to catastrophic aortic dissection, rupture, or even a massive embolic stroke from floating plaque fragments that get knocked loose. Because of this massive hazard, the surgeon absolutely has to modify the surgical plan to a no-touch off-pump technique or pursue alternative percutaneous options. Let's apply that to question 20. A 76-year-old male is diagnosed with severe calcific aortic stenosis. He has a high frailty index, a severe porcelain aorta, and an STS predicted risk of mortality of 12% for open heart surgery. Knowing the immense dangers of a porcelain aorta, what is the most appropriate management strategy for this highly vulnerable patient's valve disease? A. Mandatory open surgical aortic valve replacement. B. Transcatheter aortic valve replacement, or TVR. C. Is strict bed rest and high-dose beta blocker therapy. Or D. Referral to home hospice without any intervention.
The correct answer is B, transcatheter aortic valve replacement, widely known as TAVR. TAVR completely bypasses the tremendous morbidity of a median sternotomy, aortic cross-clamping, and cardiopulmonary bypass. It offers a critical lifeline to these prohibitive risk patients. Because this patient is elderly, highly frail, and has that super dangerous porcelain aorta we just talked about, deploying a bioprosthetic valve directly within the native stenotic orifice via a transfemoral catheter is really the definitive standard of care alternative.
Finally, let's nail down this critical postoperative pharmacology parameter with question 21. Following a mechanical mitral valve replacement, a 42-year-old female is started on long-term warfarin therapy. What is the standard target international normalized ratio, or INR range, required to prevent thromboembolic complications while minimizing the risk of a major hemorrhage? Is it A, 1.5 to 2.0, B, 2.0 to 3.0, C, 2.5 to 3.5, or D, 4.0 to 5.0? And the correct answer is C, a target INR of 2.5 to 3.5. So mechanical heart valves are incredibly thrombogenic, right? They absolutely mandate lifelong vitamin K antagonists like warfarin. But because the mitral position has significantly lower blood flow velocities and a much higher baseline thrombosis risk compared to the aortic position, we really have to maintain this stricter 2.5 to 3.5 range. Managing this delicate balance is a tremendous lifelong burden for the patient, which honestly leaves us wondering, how soon until percutaneous innovations eliminate the need for mechanical valves and lifelong warfarin altogether?